sexual orientation at an age when they could most benefit. And as I mentioned, they did take into consideration the cost-effectiveness analyses. Quadrivalent vaccination of males was considered using grade. ACIP had just adopted grade in 2011. The recommendation was a category A and evidence type 2. And the recommendations are essentially what we have now. And I do want to mention that the United States was the first country to include routine vaccination of males in the National Immunization Program. And most countries that have introduced HPV vaccination still only have a female program, although more are adopting a gender-neutral vaccination program. The last policy change I will mention is the one in 2015 when ACIP considered the 9-valent vaccine. FDA licensure for this vaccine was based on efficacy trial conducted in females and immunobridging studies in females and males. And ACIP reviewed 9-valent vaccine using grade. ACIP also, again, reviewed cost effectiveness at that time, and vaccinating females and males with 9-valent vaccine was estimated to be cost savings compared to quadrivalent vaccine. And the modeling that was performed considered the current policy for females and males and did not reconsider the age recommendations for males. Recommendation for 9-valent vaccine was a category A. Evidence was type 2 for females and type 3 for males. And the lower evidence on males was based on the fact that only immunobridging data was available for the 9-valent vaccine. So over the past year or so, the work group has started consideration of harmonization of the upper age for females and males. This would simplify the immunization schedule and might facilitate reaching males, including high-risk males. And so for further background, the last part of this talk, I want to briefly review coverage in the US. ACIP has seen the NIS teen data before. Coverage has been increasing in females, but slowly, shown in orange and red, reaching about 65% for at least 1-dose coverage and 43% for 3-dose coverage. And in males, in the blue shades, coverage has been increasing since the routine recommendation in 2011, reaching 56% for at least 1 dose and 32% for 3-dose coverage. And for older individuals, we have self-reported data from the National Health Interview Survey. This slide shows estimated at least 1-dose coverage among 19 through 26-year-olds. There are 3 sets of bars for females and males. These are the 19 through 21-year-olds, 20 through to 26-year-olds, and the overall 19 through 26-year-olds. And in 2016, for females 19 through 21, at least 1-dose coverage was 51%, and for 22 to 26-year-olds, 47%. And you can see on the right that coverage was lower in males in all of these age groupings. Most of the differences between females and males are due to the 5-year difference between when the routine vaccination was made for females and males and the time it takes for vaccinated individuals to age into these older age groups. Since vaccination is also recommended for men who have sex with men through age 26 years, studies have evaluated coverage in this subgroup. Studies reporting coverage between 2011 and 15 are shown in this slide. Most of these studies cannot be directly compared because of differences in methodologies and study populations, but all looked at self-reported receipt of at least 1 HPV vaccine dose among MSM 18 through 26 years. And you can see that while coverage appears to be increasing, it is still quite low in 2015. So I've summarized some of the next steps for consideration of harmonization of the age recommendations on this slide. Although one of the reasons to consider harmonization is to simplify the schedule, we will also be updating ACIP on HPV-associated cancers, highlighting changes in the burden in males and females and the epidemiology of HPV in males, and some of these data will be presented today. At future meetings, we plan to summarize vaccine efficacy data in males, surveys of values and acceptability regarding the age harmonization. These have been done or are ongoing. An updated cost-effectiveness analysis has been conducted and will be presented at a future meeting, and we plan to synthesize the evidence using the Evidence to Recommendations framework. The next part of the session has 2 talks, one on trends in HPV-associated cancers and the other on epidemiology of HPV in males. Before Dr. Van Dyne's talk, I want to mention that we do not expect to see a population-level impact of the HPV vaccination program yet on HPV-associated cancers. Monitoring studies in the US have demonstrated an impact of vaccination on HPV prevalence and have shown evidence of decreases in genital warts and cervical precancers in women in their late teens and early 20s. The data on trends in HPV-associated cancers are being presented today to update ACIP on the burden of disease among males and females and provide information on the potential impact of the vaccination program. Thank you.
Thank you, Dr. Markowitz. Do you want to take questions now or wait till after the next two? You want to take them? So, Dr. Van Dyne.
Good afternoon. I'm going to be presenting on recent data on trends in HPV-associated cancers in the United States from 1999 to 2014. Human papillomavirus HPV is a known cause of cervical cancer, as well as some oropharyngeal, vulvar, vaginal, penile, and anal cancers. Cervical cancer is the only HPV-associated cancer with screening guidelines. There currently are no screening guidelines routinely recommended for other HPV-associated cancers. Because of the long latency period from initial infection to cancer diagnosis, we do not expect to observe changes in HPV-associated cancers due to vaccination at this time. The objective of this presentation is to provide an update on the epidemiology and burden of HPV-associated cancers, and this could help us understand where the HPV vaccine could have an impact. We will use data to examine trends of HPV-associated cancer types in the U.S. population, looking at these cancer types by age, sex, race, and ethnicity. Cancer registries do not routinely collect HPV genotyping information. Other studies collect genotyping information, which can then be used to estimate the percentage probably caused by any HPV type. We defined an HPV-associated cancer as cell types in which HPV DNA is frequently found. These include carcinomas of the cervix, which are squamous cell carcinomas, also called SCCs, adenocarcinomas, and other carcinomas. With other sites, there are only squamous cell carcinomas. These include squamous cell carcinomas of the oropharynx, vulva, vagina, penis, and anus, so do not include, for example, sarcomas and melanomas. In addition, the case definition includes being invasive and histologically confirmed. Cancer data are collected through cancer registries located in all 50 states, the District of Columbia, and Puerto Rico. Data are reported to 2 federal registry programs, as shown on the map on the right. These 2 programs are CDC's National Program of Cancer Registries, NPCR, which is in blue, and the National Cancer Institute, NCI's Surveillance, Epidemiology, and End Results, SEER program, in green. During 1999 to 2014, the most recent data available, registry data that met specific quality standards covered approximately 97% of the US population. Average annual percent change, also called AAPC, is a common method to examine cancer trends using statistical software. AAPC is a summary measure, a weighted average of percent change per year of cancer incidence rates. For example, an AAPC of 3 would be an annual increase of 3% per year. Statistically significant AAPCs were different from 0 at the alpha 0.05 level. Rates and trends were calculated by sex, age group, race, and ethnicity. Data were age adjusted to the 2000 US standard population, and data were suppressed for rates if cases were less than 16 per period. There are 34,864 cases of HPV-associated cancer diagnosed annually from 1999 to 2014. The figure on the right shows 38% were among males and 62% were among females. The incidence rate was 11.4 per 100,000 persons per year. These pie charts show data on HPV-associated cancer by site and sex in 1999 to the left and in 2014 to the right. Cervical cancer, in dark red, was 44% of all HPV-associated cancers in 1999 and decreased to 27% of all HPV-associated cancers in 2014. Oropharyngeal cancer among males, which is in dark blue, was 23% of all HPV-associated cancers in 1999 and increased to 35% of all HPV-associated cancers in 2014. In 1999, 34% of all HPV-associated cancers were among males, and in 2014, 44% of all HPV-associated cancers were among males. This figure shows trends for all the HPV-associated cancers from 1999 to 2014. Year of diagnosis is on the x-axis and incidence rate is on the y-axis. At the top, rates of cervical cancer, which is in dark red, decreased, and oropharyngeal cancer among men, which is in dark blue, increased. The lines cross over in 2009. In 2014, oropharyngeal cancer among men had the highest incidence rate. At the bottom are vaginal, penile, anal among men and women, vulvar, and oropharyngeal cancer among women. Rates increased for oropharyngeal cancer among women, which is in green, anal cancer among men, which is in light blue, and women, which is in pink, and vulvar cancer, which is in gray. Rates of penile cancer, which is in yellow, and vaginal cancer in orange were stable. I will discuss cervical, vulvar, anal, and oropharyngeal cancer trends in more depth. First, I will start with cervical cancer rates. For cervical cancer, the rates decreased 1.9% per year from 1999 to 2014. This decrease, illustrated on this slide, continues a trend observed starting in the 1950s with the introduction of the pap smear, when the incidence of invasive cervical cancer declined dramatically. Of note, not shown on the slide, between 1955 and 1992, cervical cancer incidence declined by more than 60% in the United States. This table shows the average annual percent change and 95% confidence interval for cervical cancer by age group. Ages 15 to 19 were suppressed as there were too few cases. Overall, a decrease was seen among all age groups. For women ages 20 to 24, the rate decreased by 3.8%, and among women greater than 70 years, the rate decreased 3.2% per year from 1999 to 2014. Next, we will look at cervical cancer by race and ethnicity. Rates decreased the most among Hispanics, which is the top dotted line, and non-Hispanic blacks, the dashed line. However, rates were also the highest for these two groups. Cervical cancer decreased in all groups except American Indian, Alaska Native. We looked more in detail at cervical cancer trends. This slide shows trends for squamous cell carcinoma, adenocarcinoma, and other carcinomas. From this analysis, the histologies of cervical cancer that declined were squamous cell carcinomas and other carcinomas. Adenocarcinomas were stable and arise from cells that may be more difficult to sample during screening as they occur in the endocervix. HPV types that cause both squamous cell carcinoma and adenocarcinoma are targeted by the HPV vaccine. In the future, we would expect to see declines in both squamous cell carcinoma and also adenocarcinomas. This is a figure of vulvar cancer trends. Rates increased 1.4% per year from 1999 to 2014. and this is a figure of anal cancer trends. Rates increased among females, which is in dark red, and males in dark blue. For females, the rate increased 3% per year from 1999 to 2014. For males, rates increased 2.3% per year for the same time period. Several factors could contribute to the increase in anal cancers. Changing sexual behaviors have been investigated, including receptive anal intercourse. Because oropharyngeal cancers are increasing in men particularly, I'm going to present some additional data for this HPV-associated cancer. To begin with, the figure on the left shows the locations of oropharyngeal cancer. These include the soft palate, the side and back walls of the throat, the tonsils, and the back 1/3 of the tongue, which will also be called the base of the tongue during this presentation. As I mentioned earlier, oropharyngeal cancer rates have increased among men and women from 1999 to 2014. Of note, approximately 70% of oropharyngeal cancers are thought to be due to HPV, and this is lower than the 90% of cervical and anal cancers that are thought to be due to HPV. The rate of oropharyngeal cancer increased 2.8% per year among men, which is in dark blue, and 0.8% per year among women in dark red from 1999 to 2014. Several factors such as tobacco use, alcohol use, and oral sex behaviors could contribute to oropharyngeal cancer risk. Studies have shown that the increase in oropharyngeal cancer is probably due to increases in oral HPV infection. And more on this will be explained during the next talk. This is a figure, this figure shows trends by age among males. Oropharyngeal cancer among men are increasing the most among the older age groups. The rate increase was highest among men ages 60 to 69 and increased 4% per year from 1999 to 2014. And for comparison, rates were stable among women in the same age group. This is a figure of oropharyngeal cancer by race and ethnicity among men. Oropharyngeal cancer rates increased among non-Hispanic white and Asian Pacific Islander, and rates decreased among non-Hispanic blacks. Of note, among black men, special studies have shown a smaller proportion of cancers are attributable to HPV compared to other racial and ethnic groups. Because cancer registries do not routinely collect HPV genotyping data, we looked at sites in the oropharynx that are more commonly HPV DNA positive. These are in the tonsillar regions and the base of the tongue. Rates of oropharyngeal cancer among men increased 3.7% per year at the base of the tongue and 3.5% per year at the tonsils. Rates were stable at other sites. Specifically, it is the sites where HPV DNA is the most prevalent that are the sites where registry data has shown an increased trend. Among women, trends are somewhat similar to men, as oropharyngeal cancer rates have increased among non-Hispanic white and decreased among non-Hispanic black populations. Although rates are much lower among women, this is a new finding to see an increased rate among a subgroup of women. Finally, this is my last data slide. This figure shows the incidence rates of cervical cancer and oropharyngeal cancer among males by age. Overall, cervical cancer peaks at a younger age than oropharyngeal cancer, but the incidence rates are much higher for oropharyngeal cancer among males above age 49 years. The median age of diagnosis for cervical cancer is 49 years, and the median age of diagnosis for oropharyngeal cancer among males is 59 years. This shows that there may be a different amount of time for a vaccine impact between these two groups. The strengths of this study include that it is a systematic population-based approach to monitor HPV-associated cancers in the United States. It uses high-quality data from cancer registries. It covers the entire US population, so can be used to look at rare cancers that cannot be looked at with other data sets. This study also assesses trends among age groups and by race and ethnicity. Limitations include that registries do not routinely collect information on HPV DNA status in cancer tissue, so it can only look at HPV-associated cancers. Reporting of race and ethnicity uses data from medical records, which might be inaccurate in a small proportion of cases. In addition, registries do not necessarily identify high-risk groups. In summary, HPV-associated cancer rates are changing from 1999 to 2014. Rates increased for oropharyngeal cancer among men and women, anal cancer among men and women, and vulvar cancer. Rates decreased for cervical cancer, and rates were stable for penile cancer and vaginal cancer. In conclusion, oropharyngeal cancer is now the most common HPV-associated cancer and increasing, particularly among males. In the future, the HPV vaccine should decrease the burden of HPV-associated cancers, but it may take decades to see population-level impact due to the length of time between the initial HPV infection and the development of cancer. Thank you.
Thank you. We'll go on to the last, and then we'll take questions from all three.
Good afternoon. I would like to get started with an outline of what I'll cover during my talk today. I'll start with a presentation of results from recent studies that have shown that HPV infection is the cause of this rise in oropharynx cancer incidence in recent years in the United States. And I'll show that this increase for HPV positive cancers has been most apparent in men in the United States. I will then move to a review of the epidemiology of oral HPV infection. Again, I will show that much like the cancers, oral HPV infections are more common in men than in women in the US population. I will also cover some of the state of the science in terms of our current understanding about the natural history and the pathogenesis of oral HPV infection and the development of HPV positive oropharynx cancers. And I'll close my presentation with a brief discussion of currently available opportunities for the prevention of these cancers. So you have just heard that the incidence of oropharynx cancers has been significantly increasing in the United States since 1999. In fact, this increase in the US has been occurring since the 1980s. So about 10 years ago, the reasons for this increase were unclear, and we, as well as others, hypothesized that this increase could be related to HPV infection, given emerging molecular and epidemiologic evidence at that time that showed an etiologic role for HPV in oropharynx cancers. So to test this hypothesis, our group conducted a molecular epidemiologic study in 3 cancer registries in the United States. For this study, we retrieved archived tumor tissues for oropharynx cancers that occurred in the 1980s, in the early 1990s, in the late 1990s, and the 2000s, and we tested for the prevalence of HPV infection in these tumor tissues using a variety of molecular assays. On this figure on your left, I'm showing you the results for HPV prevalence by the PCR assay. As you can see here, during the 1980s, approximately 16% of oropharynx cancers were caused by HPV infection. And this proportion has significantly, substantially increased over time into the recent calendar years. For oropharynx cancers that occurred during the early 2000s, as many as 72% were caused by HPV infection. Now, it bears noting here that a vast majority of these HPV positive oropharynx cancers were caused by one HPV type, HPV-16, which has key implications for prevention through prophylactic HPV vaccination. Now, given that we had the HPV status of the tumors in these cancer registries, we were able to take the overall oropharynx cancer incidence rate, shown on the figure on your right in black, and we were able to compartmentalize that into incidence rates for HPV positive oropharynx cancers, shown in red, and incidence rates for HPV negative oropharynx cancers, shown in blue here. And through this analysis, we were able to show that this overall increase in oropharynx cancers in the United States in recent years arises exclusively from a rise in the incidence of HPV-positive oropharynx cancers. When we look at the incidence trends for HPV-positive oropharynx cancers separately by gender, I'm referring to the figure on your left here, we see that incidence rates for HPV-positive oropharynx cancers have increased substantially over time in men, while in women, the increase has been slight, if at all. So this shows that HPV-positive oropharynx cancers in the United States primarily occur in men. Now, if these rising incidence trends were to continue into the future, I'm showing you the projections on your right from age period cohort models, and these projections indicate that soon HPV-positive oropharynx cancers would be the most common HPV-associated cancer in the United States. HPV-positive oropharynx cancers are also slated to become the most common head and neck cancer in the US by the year 2030, with the vast majority of the burden in men. Moving to the epidemiology of oral HPV infections in the US population, very similar to the higher incidence of HPV-positive oropharynx cancers in men, in the US population, the prevalence of oral HPV infection is significantly higher in men than it is in women. And this is true for infection with any of 37 HPV types that we generally test for in the oral samples. And it is true for HPV-16 infection as well, that I told you causes a vast majority of the oropharynx cancers. Oral HPV infections are primarily acquired through sexual activity. On these figures here, I'm showing you how the prevalence of oral HPV infection changes with an increasing number of lifetime sexual partners, be it for any type of sex shown on your left, and specifically for oral sex shown on your right. As you can see in these figures, with an increase in the lifetime number of sex partners, oral HPV prevalence increases strongly in the US population. Now, in both men and women, oral HPV is extremely rare in the absence of sexual activity. This indicates that in both genders, oral HPV infections are primarily acquired and are attributable to sexual activity. So men in the United States do tend to report a higher number of sexual partners. I'm showing you here separately the mean lifetime number of sex partners, separately for men and women, for any sex, oral sex, as well as vaginal sex. So as you can see here, men tend to report a higher number of partners. But when we try to use this to adjust the excess of oral HPV infections in men, we see that these behaviors explain a small proportion, approximately 18% of the male excess of oral HPV infections. So in the last slide and this slide, I'm showing you that neither a different mode of transmission of oral HPV infection nor sexual behaviors seem to explain this male excess of oral HPV. What we in fact find is that this male predominance of oral HPV arises from stronger associations of sexual behaviors with infection prevalence in men when compared with women. And on this slide, I'll try to explain what I mean by that. On this figure, I'm showing you how oral HPV prevalence increases per each additional lifetime sexual partner, separately for men and women. The results are shown in red for men and blue for women. Let's start with the women here. You'll see that with each additional sexual partner, infection prevalence increases, and this increase plateaus around 10 lifetime sexual partners. Now contrast that with what we see for men. With each additional sexual partner, the prevalence of oral HPV infection increases steeply compared with women, and this increase tends to plateau at about 25 partners compared to 10 sexual partners in women. So men appear to be uniquely susceptible to acquiring oral HPV infections because the same behaviors are having a disproportionately greater impact on oral HPV prevalence in men compared to women. Now, the reasons for this unique male susceptibility are not entirely known at this time. One hypothesis is that men are more immunologically susceptible in general to HPV infection. And consistent with this hypothesis, we see in the US population lower rates of seroprevalence in men compared to women. On this figure, I'm showing you the CDC data for seroprevalence of infection with one or more of the 9 HPV types that are included in the nonavalent vaccine. And I must note here that these are seroprevalence data in the pre-vaccine era, before the introduction of the vaccine in the United States. As you can see here, at any given age group, men show lower seroprevalence rates when compared with women. This lower seroprevalence arises from lower rates of seroconversion after genital HPV infection in men and women. So this potentially relates to the gender differences in the anatomic site of genital infection. In women, genital infection generally tends to be at a mucosal surface where the immune system has ready access to the virus and is able to mount a robust immune response. Whereas in men, the genital infection tends to be at a keratinized site where the immune system does not have ready access to the virus and are not enabling the development of a strong immune response. Now, the hypothesis here is that this robust immune response to genital infection in women is somehow protecting them against oral HPV infection. Consistent with this hypothesis, specifically for oral HPV infection, we see that oral HPV viral load, it is a surrogate for host immune control of the virus, is significantly higher in men with prevalent infection than in women with prevalent infection. Perhaps as a result of these immunologic differences between men and women, we tend to see very different age-specific prevalence patterns in females and males. On this slide, I'm showing you on the left CDC data for the years 2013 and 2014 for the prevalence of genital HPV infections in men and women. And on the right figure, I'm showing you the age-specific prevalence of oral HPV infection in men and women. So cervical HPV infection or genital HPV infection in women peaks in the mid-20s, and we see a continuing decline at older ages. By contrast, genital HPV infections in men do not decline at older ages. We tend to see an increase and a somewhat of a plateau at older ages. Now let's move to the right in terms of oral HPV prevalence. We see a very atypical bimodal prevalence pattern with an initial peak in the mid-20s, a decline, and a later peak which is equal to or even higher than the first peak around ages 55 to 60 years. Now, the reasons for this atypical bimodal pattern are not entirely known at this time. Potential hypotheses could include a combination of acquisition of new infections at older ages, reactivation of latent infections due to age-related immune senescence at older ages, or a birth cohort effect. And the reality could be a combination of all of these hypotheses. But suffices to say that we do not really see an age-related decline in the prevalence of HPV infections at any site in men. Now, I recognize that I'm showing you prevalence of infection across ages on this slide. What we would really like to know is what is the disease relevance of infections acquired at the different ages. For cervical HPV infection and cervical cancer, modeling studies based on natural history data show that up to 75% of all cervical cancers are caused by infections women acquire prior to age 30. Unfortunately, for males, we do not have these natural history studies or the modeling studies to tell us what the disease relevance is, specifically for the infections acquired at older ages. So moving to the natural history and pathogenesis of oral HPV infection and the development of HPV-positive oropharynx cancers, unlike for cervical cancers, where over the past few decades, large natural history studies have been conducted worldwide, and these studies have mapped out the transitions from initial infection to the development of persistent infection to the development of precancerous lesions, and then progression to cancer. Unlike this paradigm for the cervix, we have very few natural history studies for oral HPV infections. So the steps intervening the initial establishment of infection and the later development of HPV-positive oropharynx cancers are largely unknown. What we currently know about this disease is we know what are the risk factors for oral HPV infections and HPV-positive oropharynx cancers. We have good estimates for prevalence of oral HPV infections in the United States. Although limited data, we do have some estimates for incidence of oral HPV infection as well as persistence. This is what we know today. There are many unknowns in terms of the natural history of this disease. Most importantly, we do not yet have an identified HPV-induced precancerous lesion in the oropharynx. As I just noted, we do not know the time from initial establishment of infection and how long it takes for the development of the cancer. And again, as I just noted, we do not know the disease relevance of infections acquired at older ages. So our understanding regarding the natural history of oral HPV infections and HPV-positive oropharynx cancers is still at a very nascent stage. But I would like to take you back to why we think we are seeing these increases for oropharynx cancers in the US population. I showed you that HPV infection is the cause of this increase, and given that oral HPV infections are primarily sexually acquired, the prevailing hypothesis in the field is that changes in sexual behaviors in the birth cohorts that went through the sexual revolution in the United States have led to increased exposure to oral HPV infections, and this increased exposure is now manifesting as increase in HPV-positive oropharynx cancers. Now, specifically for men, I showed you that the same sexual behaviors could have a disproportionately greater impact on oral HPV infection in men, and we think this is the reason we are seeing this rising incidence, which is most apparent in men today. Let's move to what we can do in terms of screening and prevention of this disease. Secondary prevention through screening is not currently feasible for this disease because, as I just mentioned, we do not have an HPV-induced precancerous lesion identified at this time. Even if we were to identify an HPV-induced precancerous lesion, many questions remain unanswered. We do not know how to screen in terms of the methods for screening. We do not know how to treat screen-positive individuals in terms of how we can reduce their risk for progression to cancer. And we do not have estimates of cost effectiveness of population-based screening in any population. Now, given all of these unanswered questions, screening with oral HPV tests is not currently recommended for this disease. So given this inability to screen and prevent in a secondary fashion for this disease, this underscores the importance of potential for HPV vaccination. And we do have some data in the literature that support high efficacy of the vaccines against oral HPV infections. On this slide, I'm showing you results from the NCI Costa Rica vaccine trial of young women. So approximately 4 years after receipt of 3 doses of vaccination in this particular randomized trial, we see a substantial reduction in oral HPV prevalence in the vaccinated group when compared to the control group, with an efficacy estimate of approximately 93%. When we look at the US population of young adults, these are data from NHANES, so they are self-reported vaccination status. And when we compare individuals who reported receipt of at least 1 dose of the vaccine against unvaccinated individuals, in both men and women, we see a reduction in oral HPV prevalence. This reduction in women did not reach statistical significance, perhaps given the very sparse sample sizes in this group. But in men, we do see strong and significant evidence of reduction in oral HPV prevalence. And I must note here, this is prevalence for the 4 vaccine types included in the quadrivalent vaccine. So I'd like to close with a summary of what I presented today. I showed you that HPV infection is the cause of rising oropharynx cancer incidence in the United States. I showed you that both the cancer as well as oral HPV infections are more common in men in the United States. Given that screening and early detection for this disease is not particularly feasible at this time, and given that a vast majority of HPV-positive oropharynx cancers are caused by HPV-16 infection, HPV vaccination of young individuals at this time presents the most promising prevention strategy. So I'd like to stop there and would be happy to answer any questions.
Thank you very much for that nice summary. Do we have questions for any of the 3 presenters, Dr. Markowitz, Dr. Van Dyne, or Dr. Chaturvedi? Questions? Yes.
Carol Hayes with the American College of Nurse Midwives. Did you have any stratified data on sexual preference? In other words, was the HPV rate higher in men who have sex with men, oropharyngeal cancers, or in women who have sex with women who have oral sex with women? So I'm just curious if there was any data in there relevant to that.
So I'll preface by saying that these are self-reported data that we have looked at within the NHANES. So that should be taken into consideration in the interpretation of the results. But what we tend to see is MSM compared to heterosexual men, we do not see vast differences in prevalence. We see approximately equal oral HPV prevalence in these 2 subgroups. We see something different in women. When we compare women who have sex with women with heterosexual women, we tend to see very high rates of infection in women who have sex with women compared to the heterosexual women. So we see a contrast in how the prevalence compares across these sites. Now, again, I'll also say that these are not potentially adjusted for the purported infection status of the partner. That could contribute to some of these differences as well. Does that answer your question?
Dr. Riley.
So dysplasia doesn't happen in the oropharynx?
So there are a few reported cases that have found that in cancers, let's say the cancer is in the left tonsil. If we go into the contralateral tonsil that has also been surgically removed, and we look there, we see some evidence of dysplasia, but as yet we do not have a lesion in terms of a detectable through some visualization modality. We have not seen that. I must also add here that some studies have tried to do an analog of pap smear through cytology of the tonsils, and those studies have consistently failed to show a detectable precancerous lesion.
Dr. Hunter.
Just a comment. It seems to me this is very, very useful information and very conceptual, but when it comes to making an actual recommendation, especially with the indications we have and the data we're looking at as a group, I don't see how we're going to be able to incorporate oropharyngeal data of any kind into our recommendations of how we do it. And the other thing is, even if we were, it seems like we're already starting with the data that makes the difference, in that we're starting with HPV in areas that we can detect in the vagina in particular, which I assume is the source for the oropharyngeal in the men. So I think if we focus on the data that we know, we'll make the right decisions for the men in the long run. I mean, can you comment on those comments?
So I think it's safer if I defer to Dr. Markowitz, but I'd like to say that, as you just mentioned, oropharyngeal cancer is not an indication at this time, which is somewhat problematic. And I'll just defer to Dr. Markowitz on answering that particular question.
I'm not really clear I understood exactly what you were getting at, but I think it is true that that there is no indication for prevention of oropharyngeal cancer, because part of that is because it's been not possible to do the clinical trials because of the fact that there's no precancer lesion. However, this presentation was shown just to discuss and really illustrate the burden of disease in males and to give some background on the epidemiology in males to kind of broaden the picture of the burden of HPV-associated disease in the United States. So I agree that we can't use these data specifically. However, we have been saying in our recommendations all along that even though we don't have data, it's likely that vaccination will prevent all HPV attributable disease, and that's something we've been saying in our recommendations.
Dr. Stevens.
The 90% incidence of our association with HPV-16 is interesting. Can you comment a bit more on why that's different, or why you think that may be different for oropharyngeal versus cervical?
So I'll start by saying that the reasons are not entirely clear at this time. It is something that we've seen not just for the oropharynx. And I must apologize, I couldn't tell where the question was coming from, so, okay, great, sorry. What we see is in the cervix, the 16 and 18 types, 16 being about 50% and 16 and 18 together, as you know, being about 70% of the attributable fraction, and the remainder of the high-risk types account for the cancers. When we move outside of the cervix and we look at extracervical HPV-associated cancers, for some reason, HPV-16 really predominates. It is true for anal cancer, where a vast majority of the HPV-positive cancers are caused by HPV-16 infection. And in several of our studies around the world, we have seen that when an oropharynx cancer is caused by HPV infection, it tends to be because of HPV-16. It tends to be caused by HPV-16 infection. And I'm not aware of a clear biological explanation for why that is, other than that HPV-16 is thought to be the most carcinogenic of all of the HPV types.
Dr. Hahn.
Yes, I'm right here.
Hi.
I was wondering, is there, with the late onset in males that you were showing, is there any evidence that they're acquiring HPV-16 later, and therefore vaccinating males later might have a benefit?
So we really do not have the natural history studies to actually say what the disease potential of infections acquired at later ages is. So all we can do is go back to the cervical cancer model, which may, or I must admit, may or may not entirely apply to the oropharynx. But looking at the cervical acquisition as well as the development of cervical cancer, at least we can, for the cervix, know that most of the infections that do later on lead to cancer are acquired early on. For the oropharynx, I really feel like we need the natural history studies to really understand what is the hazard of acquisition of the infection at older ages. Not just the hazard of acquisition, what is then the hazard of these incident infections to potentially progress to cancer. And one surrogate that we've used in all of our HPV work is HPV persistence as that intermediate endpoint. So until we have that information, we really, I don't think, can conclude about the disease relevance at older ages, which brings us to, if we cannot conclude that, we really cannot conclude about the potential for vaccination, at least at those older ages at this time.
Dr. Romero.
So this deviates a little bit from what you're talking about, but if you go lower in the respiratory tract, laryngeal papillomatosis in children, is 16 still the predominant type there? Do you know?
Recurrent respiratory papillomatosis and laryngeal papillomatosis is more caused by the low-risk HPV types, the ones that are more likely to cause warts. These are HPV type 6 and 11.
Other questions, comments? Well, thank you very much to the HPV group. This has been a really interesting presentation, and especially so late in the day, you obviously garnered a lot of attention despite our fatigue. I think we have public comment now, and I believe there's only one.
Thank you.
So we have one person signed up for public comment at this time, Ms. Woodruff, if you want to come up. In the meantime, while you're walking up to the microphone, I want to tell you guys what the adjusted agenda will be for tomorrow. We are going to start at 8 a.m., and the hepatitis A group is going to bring forth revised recommendations based on feedback from the committee today. We hope to start the pneumococcal session at 8:30. Which would put the evidence-based recommendations discussion, which was supposed to be scheduled for today, at 10 o'clock tomorrow morning, and then we will hope to get back on schedule with the rest of the session, and we will move agency updates to the end of the day if we have time, and if we don't have time, we can incorporate them into the minutes at the end. Sorry, Ms. Woodruff.
Increasingly voting for non-FDA approved off-label use of various vaccines. Are you also ensuring that the patient or the parent knows about this in writing at the time that the vaccine is administered, and that the information is going to be used for trial purposes? That's my only comment. Thanks.
Repeat the very last part of that comment. Oh, that's okay. Did you catch it?
My understanding is the information is going to go into a database for trial purposes. And so just so you can make sure that the patient knows that this is ACIP recommended but not FDA approved, the information is going in for trial purposes, it just seems like it would be a better idea to preserve the integrity of the recommendation if we're just very clear what's what. Thanks.
Thank you for that clarification.
Seeing none, I believe we are adjourned. Thank you very much for all the hard work today.
And we will see you at 8 a.m. tomorrow morning.
Yes.